Okay, if you guys want to start, go ahead, Sierra and Erin. Thank you.
Sure, thank you. Let's see. Sierra, do you know if I just share my screen, will that go to the PowerPoint that I have opened up here?
It should give you an option for which screen, yeah.
Okay. All right, are you guys able to see?
Not yet.
This is Cindy. You can't see me, but I can hear you.
Okay. Yeah, I also don't have a camera on my computer either, so I was trying to share my screen so I can show you guys some slides.
Yes, I see the slides.
Okay, maybe.
It looks like it's working now.
Working now?
Yep.
Okay, cool. All right, so Cindy and Danielle, right?
Yes.
Okay, great. Thanks for joining us. My name is Erin, and this is my coworker and colleague Sierra, and we're both pharmacists at work at UC Davis, and we work specifically in the burn ICU and with the burn floor patients. And so we really appreciate you guys having us today, and Lauren for inviting us to meet with you. We wanted to make this a pretty informal and leave a lot of time for like any Q&A that you guys might have, questions, or for sharing experiences. So the slides are going to be really pretty short, but then hopefully if you guys have any questions, if Sierra and I don't know the answers, at least maybe then we can find them and then get back to you with some answers if you guys have any specific questions. So we'll jump right into it. So what exactly do we do? I think a lot of people who are in the community maybe don't even know that pharmacists work in the hospital, let alone in the ICUs or within specific areas of the hospital like the burn unit. But we do, and we're there every day. And we work extremely closely with the providers, the nurse practitioners, the docs, the nurses, respiratory, physical therapists, on a day-to-day basis. We're very much kind of in the background, but we do really value the team and enjoy taking care of you guys and helping with anything and everything med related. And so I just listed some of the main things that we do for patients or do within the ICUs, just to kind of orient you to what our role is. We do medication reconciliation. So that means essentially when patients come in, we talk to them, try to figure out what they're taking before they come into the hospital. I spend a lot of my day helping with the management of pain and anxiety. As you guys know, as burn survivors, that's a huge component of your care. Infections are also a huge thing that burn patients encounter. And so we spend a lot of time dosing, monitoring, looking for the patient's next infection and making sure we get on top of it as quickly as possible, treating it with the right antibiotics at the right dose as well. Dosing of medications in the burn subpopulation is a really unique category because there is a lot of research in the effect that the burn injury itself has on the metabolism medication. So we help out a lot with that. As our population ages and our care of burned patients has improved so much, we, as you guys may have learned from other patients or just from being in the hospital setting, that some of our burn patients are 70, 80 years old, and a lot of them do carry pre-existing conditions as well. And so our burn team and our burn surgeons are great at managing the actual burn and the surgical issues, but a lot of times we'll help out with some of those morbid conditions that patients have coming into it, like diabetes, heart failure, hypertension, etc. And then just a bunch of general ICU care. So making sure patients' blood sugars are controlled, patients are on the right medications to prevent more harm down the road, and then provide drug information. So if providers have questions or anything, exactly, nurses have questions, anything and everything med related, I think is what we consider within our scope. Sierra and I were trying to brainstorm what we should talk about because pharmacy is such a large, broad topic. And that's why we wanted to make this kind of informal. But one of the things I thought about that might be interesting, and you guys may or may not have heard about it or experienced it yourselves, is this phenomena or this syndrome called post-ICU syndrome, PICS. And so it's been known kind of around, like, categorized around the last decade, but more recently, especially with the COVID-19 pandemic and having a lot more patients, which is a really large percentage of our population that experienced critical illness and survived it, this is becoming more and more prevalent, and we're seeing a lot more of this. And so just making sure, definitely not an expert on this, but something that you guys know exists, and that if you're experiencing it, it's not unusual. So what exactly is it? Syndromes are notoriously poorly defined, right? So a syndrome is just a collection of either signs or symptoms that make up what we think is maybe not necessarily a disease, but what am I searching for? Like issues is not the right word, but like a collection of problems, I guess. And so PICS, or post-ICU syndrome, can involve the body, which could just be like a significant weakness. You could experience like a neuropathic pain or a neuropathic weakness. You might not be as strong as you were prior to your illness, or it might take a lot longer for you to do things, or you may become really winded with doing something basic that wasn't that difficult for you prior to your injury. Or it could be cognitive brain dysfunction. So again, these are categories are like really broad, but these are a lot of things that patients experience post-ICU. Some of them start in the unit still or in the hospital still, and they can continue anywhere from days to weeks to months after patients return home. Really common problem. So millions of patients are getting admitted to the ICUs every year, and then about a third of them will require a ventilator, which will increase your risk of having this post-ICU syndrome. During your hospitalization, patients do experience issues maybe related to the primary problem that they came in, or their injury, in our case, your burn, or our management or treatment of the patient. So you could have problems from being on the ventilator for the treatment of the burn, or from, our attempt to treat other issues like an infection with certain antibiotics could have side effects. So there's a lot of like long-standing stuff that we just don't really know or understand. And then we know that delirium, acute respiratory distress syndrome, and sepsis all increase the chances of having this post-ICU syndrome. And they do say up to half, here it is on the slide, up to 50% of patients who are in the ICU will experience post-ICU syndrome. And it's especially higher in those who were on a ventilator, who spent more than a week in the hospital or in the ICU in this case, and those who had sepsis. So very high likelihood that a lot of our patients who were in the burn unit do experience post-ICU syndrome. And then some of the cognitive stuff that's been reported may be something that you guys have experienced yourselves personally, but anxiety is very common, depression, sleep disturbances, including, nightmares or difficulty falling asleep, difficulty staying asleep, pain, both, muscular skeletal pain and neuropathic pain, really common, memory loss or like brain fog, poor concentration, difficulty going back to work. And the other interesting thing about post-ICU syndrome is that it's not always just the patient. The family and friends can also be affected as well. So often family and friends will help their loved ones when they're injured, and they might sacrifice some things some care of themselves. And so they may be sacrificing certain normal care that they would take. And for that reason, they may be more sleep deprived, they may be more anxious, they may be depressed as well, kind of all related to that. And I think the important thing that I wanted to point out is, like, if you are experiencing this, this is not, I would not be surprised. That I would say this would be a common, especially after a lot of patients have spent time in the burn unit or in the hospital for burns. So just talk to your provider. Like I said, it's something that has been kind of defined since 2010, but especially more recently, since the pandemic, we're recognizing it and seeing it a lot more just in the last year or several months. And your provider may think it's appropriate to refer to, different services depending on what your main issue would be, whether it's like the more of the cognitive or the actual physical weakness. And so that's going to dictate maybe follow up with a certain person. And then some other things that they recommend would be sharing more. So sharing stories and experiences, which I think our burn community is actually really good at and kind of has that network. And Lauren and the FFBI are obviously already harbor that environment. But sharing stories and experiences can be incredibly therapeutic for patients experiencing this. And then another recommendation was having a diary to either, they recommend maybe starting it in the ICU. So obviously not at this point, but afterwards kind of characterizing what you're experiencing at home. And then I did list some websites here that kind of specifically talk about post-ICU syndrome. So SACM.org, which is the Society of Critical Care Medicine, and then ICUsteps.org. And then Sierra is going to talk just a couple minutes about a couple medications that we commonly encounter, prescribe, and help with patients.
Yes, thanks, Erin. So now we're going to transition gears to talk a little bit about pain medications. And like Erin mentioned, it'd be great to hear your experiences with this and kind of anything that you would be willing or want to share with us. We'd love to listen. You might need to advance the slides, Erin. So as you're aware, opioids are really the mainstay of therapy for burn pain. They can be really great to help with acute pain, as well as patients who are dealing with more chronic types of pain, which often can happen after a burn injury. But there are certain things to consider about them, meaning that they can cause respiratory depression, especially when combined with other sedating substances. They can lead to dependence, which can be bound to happen the longer that you're on them. And they can cause other unwanted side effects, kind of the most prominent one being constipation. It's important to remember that you should, closely work with your providers and, whoever's managing your pain medications at home, usually the burn clinic or your primary care practitioner, to be able to form a plan. And if your plan is to wean or decrease your meds, to not just completely stop them, because that can cause withdrawal, which is a really awful feeling. We don't want anyone to go through that, but to kind of work to wean them down if that's the plan. And if it's not the plan, that's okay too. It takes a long time to be able to manage the pain and work through all the things that happen after burn injury. But one of the things that kind of terms that have been coined in recent years is what's called multimodal analgesia. And that's kind of just a fancy way to say that we use a lot of different medications to help control pain, and in part because they have different mechanisms of action and different areas that they target in the body. So they can potentially be more helpful than just opioids alone. So we've listed a couple medications that we could think of on this slide. So Tylenol and the NSAIDs, being ibuprofen and ketorolac, are really helpful for musculoskeletal pain, as well as fever reduction, with ibuprofen being a little bit more potent if you're needing something for inflammation or anything like that. Gabapentin and pregabalin are kind of our primary agents for neuropathic pain, though if you have any sort of neuropathy at baseline before burn injury, these may not be as effective because you may already be at higher doses. So therefore, we've kind of utilized other agents. Sometimes antidepressants can be used for their ability to also control nerve pain. So we've listed a couple on the slide there. And then this was a study that Erin and I did a couple of years ago that we wanted to share with you. And it's we really asked ourselves, well, do multimodal analgesia really work? Should we be promoting this and recommending this for the patients that we see? And we looked at patients who received a burn surgery in the hospital, and we monitored their opioids for 5 days post-operatively. And what we found is that the patients who actually got at least one multimodal agent other than opioids had about a 30% reduction in their total opioids used over the 5 days. And so this kind of really helped us see that, at least in this immediate acute period, that multimodal analgesia can be really helpful and help us to utilize less opioids than originally intended. And we also didn't see any changes in pain scores from the ones that we could track. So moving into our last topic, we wanted to touch base a little bit with you guys on itching. And this is something I'm definitely not an expert in. So I'd love to hear your experiences as well. But I know that it's very common, especially after burn injury. And when you get those grafts and the grafts start healing, they can have a lot of issues with itching. You can go to the next slide. And so as I mentioned, donor sites graft, even the burn site can cause itching, and it can really disrupt quality of life, sleep, work, school, daily functions. And this seems like it's something that can happen even long after patients leave the hospital. And so fortunately, from everything that I know, it does improve with time. But I know that sometimes that can be bothersome and really at the forefront of your minds when it's happening. There are a couple things that we can do to help kind of relieve the itching. Creams and moisturizers can be used to kind of hydrate the skin. Usually you want it to be unscented, fragrance-free, just to prevent any sort of dermatitis reactions that could be happening or allergies from those ingredients. If that doesn't work, we can try antihistamines. There's a variety of them. Benadryls, hydroxyzine are kind of the most common. And then if there's allergies at baseline or you kind of want to add something onto it, you can add cetirizine or loratadine. And then we have some other creams, and gabapentin has also been shown to help with itching as well. So it can hit your neuropathy as well as itching with one drug. So that's all we had prepared for you in terms of slides, but we wanted to open it up and kind of, if you have any questions for us or any comments about any of the information that we presented, we'd love to hear your thoughts.
Hi, this is Cindy. I have a question. I was originally put on gabapentin. I'm 3 years out from my burns, and I was starting to have some really weird psychological effects that I wasn't sure if the gabapentin was causing, if it was something else. But I was recently switched to Lyrica, and I've been on it for maybe 2 months, and I feel like the mental stuff's gone. Like I felt like I was losing my mind. And is that something that the gabapentin, I was on 600 milligrams twice a day, which I guess is quite a lot, but now I'm doing the Lyrica. I do 25 milligrams twice a day, and that seems to be doing well, but that was my question and concern.
Yeah, gabapentin can, I mean, drugs act differently for every different person, but usually you can get some like brain fog, if you will, and like some dizziness and kind of not feeling right with gabapentin. Usually it resolves the longer you've been on it. You kind of get accustomed or used to it, but certainly as you your pain is changing and those things, that you may not need the dose that you were on for so long, and that may be why you were experiencing it. So I'm glad that you're having better effects with Lyrica.
Yes.
Cindy, I know people often report also, like if they miss, if they've been on gabapentin for years and years and they miss a dose or a day's worth or something, like I think people do report a lot of like withdrawal from gabapentin too. I don't know if that was clouding it, or maybe there was a new medication added, or who knows. But I would say, and Sierra, feel free to chime in, like a lot of the neuropathic pain medications, unfortunately there's not really great data as far as like what is best for every person. Like Sierra said, everybody's kind of different, and so we tend to start with gabapentin in a lot of people, but it doesn't always work best for everybody. And so that's when we start either adding on or changing around. And it sounds like the switch from gabapentin to Lyrica was probably a positive one for you. So I think that's a great point. Is just if you feel like you're having side effects from a medication, then definitely talk to your provider and let us know, and we can try something else. Because your Lyrica dose is actually pretty small relative to that. So if that's controlling your nerve pain, then I would say that's probably a good move, because the smaller, the low, like we always push like the lowest effective dose, right? We don't want anybody to ever get more than they need. We want to like get them to the effective dose and then kind of stop, because the more you push doses, usually the more side effects we're gonna expose the patient to.
Right, and that's why they started me low, but I seem to be the nerve pain's pretty good, actually better, and just the mental thing, I don't know, it was making me like anxious and angry, and it was like I didn't like who I was. So
Yeah,
anyway,
that's good.
I'm glad I'm off it.
Good feedback.
Yeah.
Because I know we've tried that. We have made that switch in some patients, and some patients have done really well, and some people don't report really any difference. But that's good feedback to hear.
And I was just going to comment on the itchiness too. That's something that's, 3 years. I mean, it's been a roller coaster ride for me with the itchiness. And right now I'm pretty good, but the Atarax, when I get really bad, I'll take 50 milligrams of Atarax, just because sometimes at night I can't sleep. It just is driving me crazy. So that's helpful for me. I just wanted to add that.
Oh, thank
Okay.
you for sharing.
And I'll go mute because I've got somebody coming to the door in a minute.
Sure.
Okay.
Thank you so much for being here for us.
Thanks, Cindy. Was your itching? Can I ask you if it was mostly on your grafted sites?
It's like really deep. Yeah, it's like it's mostly on my hands, and it's between where the skin grafts end and my skin, my real skin is, and
Gotcha.
it's like deep in there that you can't get, and you just want to scratch till
Yeah.
you can't. I mean, it's the worst feeling, but sometimes ice will help, or I just try to get up and walk or change what I'm doing and get my mind off of it. But
Just
it's
distraction.
Yeah, that's good feedback.
okay. I'll mute now. Thank you so much.
Thank you, Cindy.
Yeah.
Thank you so much, Erin and Sierra. I was going to add on, but because Cindy kind of said it, I would say that people are itchy for years for the amount of complaints that I get and the amount of people. So it's pretty interesting.
Yeah, it becomes a really chronic problem, it sounds
Yeah,
like.
yeah. But thank you guys so much for taking time and doing this. And we really appreciate it. Thank you, Cindy and Danielle, for coming.
Yeah, of course. Thanks so much, guys. It was really nice to talk to you and meet you virtually.
Yeah,
Yes, thank you. Everyone have a great day. I'm going to go answer my door.
You too.
Okay.
Thank
Bye-bye.
you. Bye, everybody.
Bye.
Bye.